I think that the default approach is to consider a mental health issue in people with epilepsy as a very likely feature.
Mental health issues are commonly part of the epilepsies. We know that seizures are just one aspect. But what happens when somebody's mental health symptoms are just too much to bear? Well, today we hear from top psychiatrist Professor Andrea Cipriani from Oxford University all about it and what we can do to decrease suffering. Please note that today's chat will include parts on suicide. So if this is upsetting or triggering for you, which it often is for me, so I totally get it, please do skip this episode and pop over to one of our others that are far more chirpy. If you're new and you haven't done so already, please do like and comment on this episode and subscribe to our channel so as to get way more people learning about the epilepsies.
I'm a psychiatrist. In this country, in the UK, my job is called clinical academic. So I see people with mainly mood disorders, treatment-resistant depression or bipolar disorder in the NHS at Oxford Health NHS Foundation Trust. But this is overall, on average, 1 day a week. For the rest of the time, I do research. I have a lab of very talented researchers and clinicians and statisticians, methodologists. We call it Oxford Precision Psychiatry Lab within the University of Oxford, because our aim is to use existing data, existing evidence to personalize treatment for people with anxiety, depression, and psychosis.
The psychiatric morbidities, I call them morbidities rather than comorbidities in association with epilepsy because they come hand in hand. Could you give us some statistics on psychiatric disease or conditions in people with an epilepsy versus the rest of the population?
As you say, these are very common features of this, what we used to divide as psychiatric and neurological disorders, but now having this brain health approach, of course, it is, we try to consider them together. And the incidence or prevalence, so how many people there are in the general population with depression, it varies a bit. There are about 300 million people in the world. But if you consider 1 in 6 or 8 people in the world has this kind of problem in the general population. So if you look at your weight in the waiting room of a GP surgery, about 1 in 6 is going to see the GP for this depression problem. In people with epilepsy, the incidence, so the number of people with depression and psychiatric symptoms is even higher. And this is a common feature of brain health disorders like Parkinson's as well, multiple sclerosis. We know about also motor neuron disease. So this big diagnosis in neurology, and there's a close link into them. So I think that the default approach is to consider a mental health issue in people with epilepsy as a very likely feature. So the crucial thing is to ask people about their mood, about their mental health, because it's likely to happen.
We first met at a really cool sort of mini conference in Rome last year. Can you tell us about that? I mean, you were our lead, basically. So what was the whole purpose of it?
Yeah, it was an experiment because with my friend and colleague, John Torie from Harvard, we used to do this, we call them summits, where we invite experts with different backgrounds to spend a couple of days together and discuss about what are the challenges and potential solutions in a specific area. We started with digital mental health, but then we realized that one of the big unmet need is to combine neurology and psychiatry into something which is meaningful for our clinical practice. And the idea was to start with a very important clinical issue like epilepsy and explore what are the psychiatric morbidities in people with epilepsy, to gather information, but also trying to brainstorm and find solutions. And I say it in experiment because we know someone in the field, but it's like a snowball. We ask these people to invite other people. And as you know perfectly, one key thing for the whole event was to have the voice of people with lived experience in the room. This is why we invited you, and you provided a material contribution to this meeting. But what we wanted to do was not only to discuss together about challenges and solutions. We wanted this to be evidence-based. So at the beginning of the meeting, we presented the results of a systematic review just to be on the same page and discuss the different topics informed by the evidence. And at the end of the meeting, the ambition was to work together, all the people in the room, co-author a paper that will be published in the scientific literature to contribute to the international discussion and debate around these topics, because we need to have an impact on clinical practice. It cannot stay within the four walls of this room.
How do you feel it went? Like, there was a lot of conversation. People didn't necessarily always agree.
Yeah, that's the beauty. That's the beauty, having different voices, different perspectives. I think there were some, I think it went very well. And we have now submitted a paper, which will hopefully be published soon. The great thing was there was an agreement, for instance, around some big challenges. So the high burden of this unmet psychiatric need in people with epilepsy. And the key thing, the key message, I think, was we need to move epilepsy care beyond this narrow focus on seizure control or SUDEP, of course. And we need to have routine screening of mental health difficulties, as I mentioned before. And also we need better research or more research understanding the psychiatric disorders in people with epilepsy. But the other important thing that came as a challenge was this need for a holistic approach, holistic care. So we need to foster the biopsychosocial approach, social aspects, quality of life, cultural, ethnicity, gender-specific aspects. These are all important. The third point is the delivery of care. So we need to have more collaborative models, embedding the voice of the patients and people with lived experience, but also expand these neuropsychiatric services where we force, in inverted commas, people with different expertise to work together and speak the same language.
You couldn't have put it more perfectly. That's what I took from our meeting as well. And yeah, it shouldn't be a stressful thing for the service user. It should be something that is managed for them. If we're unwell and need help, it's not something that we should try to juggle ourselves, right? There should be that sort of structure and almost like, I don't know, what do we call it? Multidisciplinary team, really, of clinicians who are able to talk to each other to help the individual.
Totally agree. And it was interesting because, as you probably remember, we discussed also topics that are difficult to discuss, like suicide, because the evidence is that in people with epilepsy, we have high rates of suicide. So one of the key things we need to do is to increase the education in staff around the increased risk of completed suicide, and also identify, and that's the research part, better tools to assess the risk for this individual. Because we need to help, we need to be vocal, actively ask about this, but also we need to be able to assess and stratify risk, because not everybody is the same in terms of risk. And this is where in the future I see that AI can help, because you can develop these risk stratification tools for events like suicide, using this big data that we have available and using AI to basically have better information about these risks.
And I think also, weren't we were talking about prevention of people getting to that stage as well. So how do we achieve that?
It is, of course, very almost impossible to be sure about the individual risk. So we need to work as a priori starting point. So we need to work with the person having, however, some elements of judgment. So there are characteristics that can predispose someone to complete suicide, or at the same time having psychiatric morbidities. So we need to have a starting point and then work with the patient, with the family, with the carers, and monitor over time, because that's the other important thing. I said before, I see this as a journey. It's not a one-off thing. We need to establish a relationship, and has to be mutual confidence one to the other. So I trust my clinician, and the clinician should be trustworthy. This is something we often forget, because it's not a normal job. Is to work together and trying to help people reduce the burden of the suffering. Also in Rome, the voice of people with lived experience is like fresh air and fresh blood, because it really shows and shed light on what we should do next. So also in terms of research gaps, the training and the specialist nurses, the collaboration, mental health with epilepsy specialists is fine. But also the co-production with people with lived experience should be a mandatory thing for all the funding. That is a no-brainer.
And why isn't it in so many places? It's crazy. It's kind of like the old-fashioned way of doing things, isn't it? And I do think that lots of researchers and clinicians do find it a bit scary, because it's something you weren't trained on at uni. It's still kind of a new thing. So you've kind of said it, put it in a nutshell, really, some of the benefits of working with service users or people with epilepsy or people with whatever disease, because it gives you that insight. It's not about us moaning at all. It's not about us having a go, life is unfair, even though it is. It's about working together.
As you said many times during the meeting, it is a cultural approach that we need to have. So speaking the same language, but I remember the discussions we had about a huge topic like the functional dissociative seizures. That's something that when I studied medicine last century, in the
yeah, you're not there yet, but yeah, okay.
Almost 30 years ago. No, I'm joking. 20 years ago. The problem was that we, as I said, having this medic-centered approach, we tend to put labels on things rather than understanding. And we really lack understanding of the mechanism, or as I said, these functional dissociative seizures, or how we can help people managing something, even if we struggle to find a priori something that works. Having multiple attempts and working together over time, I think helps. Because everybody's different. So we don't have pre-specified solution to problems, but the mindset should be, let's tailor the treatment to the individual in terms of treatment, as I say, but also prognosis. I need to tell people how likely is this to be recurrent? What are the implications? The side effects of medication is a crucial thing. We can't ignore important side effects that may have an impact on the quality of life of individuals, from we discussed before, gastrointestinal, constipation, diarrhea, tremor, to sexual side effects, and also in a positive sense. So sleep impact or mood stabilization and so on.
And then also I think we spoke about looking beyond medication sometimes. And actually, ideally, looking at other things before we look at medications. So how can we help support a person in their family situation, or if they need to get their weight under control? They could be underweight, they could be overweight. How can we help them get some exercise if they're able to leave the house, of course, because sometimes we're not. It's not just about drugs. I think that was a key message too, right? Absolutely.
But the non-pharmacological treatments is a huge range, because, as you say, it can be psychoeducation for the person or the family. We have also the biofeedback. I have experience with mindfulness. For some people, it's great. Other people hate it. So this is not a recipe for everyone. But what I learned from the meeting in Rome is also how important is physiotherapy for the rehab. Is a crucial aspect to take into consideration, because as psychiatrists, we tend to be because the head is separated from the body, we tend to be segmental. But actually, the holistic care approach is exactly also about the physical experience. Absolutely.
Thank you to Andrea for helping us to challenge some of the awfulness that too many of us experience, and for truly valuing patient service user input in his work. Next week, we will hear more from Andrea and about how he is advancing mental health research through his project Galenos, the Global Alliance for Living Evidence on Anxiety, Depression and Psychosis. Check out more about Andrea and his work on the website torierobinson.com, where you can access this podcast, the video and the transcription of the entire episode all in one place. And if you're new and you haven't done so already, please do like and comment on this episode and subscribe to our channel so as to get way more people learning about the epilepsies. See you next week.